Sir, everybody is enjoying our conversation, sir. All the participants are messaging too much drama. This is the pre-event kickoff talk. Kickoff. 76, right? So I think we'll wait for another 10 minutes.
Okay.
Many are joining.
I just joined 2 minutes.
$81. 5-10 minutes. We'll wait.
Priyanka.
Chat.
Hello, Dinakar sir.
What? Prashanta? ಪ್ರಶಾಂತ ಇನ್ನ ಒಂದ್ ನಿಮಿಷ ಇರು, ಬಹಳ ಜನ ಬಂದ್ ಜಾಯಿನ್ ಆಗ್ತಾರೆ. ಪ್ಲೀಸ್ ಕ್ಯಾನ್ ಯು ಹೋಲ್ಡ್ ಪ್ಲೀಸ್?
Yeah, sir. Now ready.
Another 2 minutes. Another 2 minutes.
Yeah. Okay.
I am expecting around 150 people.
Sir.
Please.
170, 118 ಆಗಿದೆ. ಬರ್ತದೆ ಸರ್, ಬರ್ತದೆ. ಆಯ್ತು. We'll wait, sir. We'll wait.
Just 3 minutes, please hold on.
sir. Because ನಂಗೂ ಮೆಸೇಜ್ ಬಂದಿದೆ ಸರ್. Just hold on ಅಂತ. ಯಾರು ಎಲ್ಲ ಕಡೆಯಿಂದ ಮೆಸೇಜ್ ಮಾಡಿದ್ರು. ಹಲೋ ಸರ್, ಆ ಕಡೆ ಸೈಡ್ ಇದ್ ಭೂಷಣ್ ಸರ್ ಇದ್ದಾರೆ ಸರ್. ಕೇಳಿಸ್ತಾ ಇದೆ ಸರ್ ವಾಯ್ಸ್?
Yes, usual smart guy.
ಬರ್ತದೆ. ರೈಟ್. ಅದರದ್ದು ಆಡಿಯೋ ಆಫ್ ಆಗಿದೆ. 126.
No, kuch no. Mobile. I'm just gonna put it on. ಪ್ರಶಾಂತ ಏನೋ ಸೌಂಡ್ ಬರ್ತಾ ಇದೆ ನೋಡಮ್ಮ. ಎಕೋ ಆಯ್ತು ಕದ.
ನಮಸ್ಕಾರ ದಿನಕರ್ ಸರ್.
Mute all Dr. Dinakar, Dr. Raghavendra, Dr. Bhushan. That's all you mute, na?
That Dinakar is watching also. Okay. We are requested that people, please everybody log in. Atle chap log in. Anta not means no. $150. 65. Wait. Select it. It's not anyone right for Raghavendra.
Anyway.
First time in the history, 72% at time logged in.
Okay.
Start.
We'll start, sir.
You start?
Let's start. It's my turn.
1 second.
Do I need to make it as play now?
Yes, sir. Make it as play, sir.
Okay, na?
Yes, sir. Yes, sir. I'll introduce, sir.
Yeah, please go ahead.
Yes, sir. Good evening, everyone, and thank you very much for participating in our NNF Karnataka chapter web series event. So it's my proud moment today to introduce my guru, under whom I did my neonatal fellowship from. Sir, thank you. First of all, thank you very much for accepting for the talk on NEC. So without wasting much of time, get into the subject and academics. Sir, please go ahead, sir, from here.
Thanks, Prashanth. Thanks for the opportunity. It feels a little weird to be talking like this on the webinar because we're not used to this. But yeah, time forces you to do things which you're not used to. So, and more importantly, to talk on a subject like pathophysiology is a little more difficult. Now, being clinicians, it's not easy and it just flows free when you want to talk on clinical subjects. But this man has tied me saying talk on pathophysiology, and believe me, much as most of us may have hated our pathology subjects during a second MBBS, it's absolutely important that we understand pathophysiology as clinicians, because all the interventions that you really put in, the therapies you put in your practice, they will have a pathophysiology as the basis to be having that logic of using that particular medicine. That is number one. So whatever the treatments you use, there's a logic or a pathophysiology understanding for that particular medicine, number one. Number two, going forwards,
Hello, sir. Hello.
Type a message and send.
Yeah. Sir, I just called him. He's connecting back.
Am I back?
Yes, sir. You can play the slide.
Sorry about the intervention. Sorry, interruption. Right. Let's get into the content right away. See, the first thing we need to understand is necrotizing enterocolitis is not an infectious disease. That's the first step. Whenever we are dealing with necrotizing enterocolitis, there are a lot of problems with infection as well. But NEC as a disease entity is got nothing directly linked to infection. That is the first statement we need to understand, number one. And obviously, from our practice point of view, it is the most worrying condition of our doctor. Why is it important? There's a lot of most of the times, even before we encounter the point of NEC, we deal with a lot of feed intolerance issues because we are so paranoid about NEC that every bit of feed intolerance, every bit of a bad aspirate, a bit of tummy distension bothers us a lot. So the point here is it is a very worrying condition. And what exactly happens at the pathological level? There is a bad ischemic necrosis of intestinal mucosa, and this is what NEC is about. Point number one we need to understand here is it is not a. Two, if you go into the features, there is severe intestinal inflammation of mucosa, there will be necrosis. And the damage can be anywhere from a mild mucosal injury to a complete tissue necrosis and tissue damage to a perforation. Typically, it happens in terminal ileum and colon. Can you just excuse me for a second? Excuse me just for a second. I think there's some kind of an emergency here. Just a second, please. Sorry about that. Now, coming to the very reasons why NEC could happen, obviously there are many theories, and we need to understand this. There are three underlying problems to a possibility of NEC happening. Number one, the very fact that we have an immature intestinal tract and a very immune system is being very immature. Two, a lot of understanding has gone into the concept called dysbiosis. I think there's a very important point in today's discussion. Dysbiosis, basically alteration in the microbiological environment in the gut due to various reasons and its impact going forwards. And then as a result of dysbiosis, a parallel problem, what's called a barrier. The third important point is what is referred to as an exaggerated inflammatory response. Immunity is quite immature. A lot of noise in the background.
Prashanth, mute everybody except the host.
Hello, sir. 1 minute.
Prashanth sir, kindly mute.
Not as developed.
You can start now, sir. You can start now. You're muted on.
Yeah, like have I come to the point of dysbiosis and mucosal barrier disruption?
Yes, sir.
I have talked about that. And yeah, the next third point is an exaggerated inflammatory response. And this is everybody believes in this now as a now unmute. Yeah. So the gut overreacts to any kind of an alteration, either in its there's something called triggers. For example, if it is not a human milk feed, if it's not the mother's milk, say if it's a formula, say if there's an infection, any of those things, it triggers a very bad, exaggerated, overreacting inflammatory mechanism, which then goes itself and then damages the gut, causing damage. Once that happens, then it becomes very susceptible to the infection. The kid becomes unwell. So three things: the immaturity of the intestines itself, the immune system being immature, then the very important concept called dysbiosis, and the third one, a very exaggerated, overreacting inflammatory response. Now coming to the maturity, now this is the first one. Why is it immature? Obviously, we need to understand. See, if you look at a term baby's length of the gut, it's about 2 meters or so. And half the length of the gut, and we have the other, yeah. Half the length of the gut actually develops in the third trimester. So if you're dealing with a 28-weeker or 29-weeker, you're basically dealing with a gut which is half the length of a term baby. So the very much what is available to you itself is half. Number one, forget about being immaturity. The content, the infrastructure itself is less. Two, these babies don't have a mucin layer which typically the term babies have. The mucosa have a very thin mucin layer which kind of throws away the gram-negative bacteria and acts as a protective antibody layer. And then they're pretty much permeable. What I mean to say is, it's an important concept we need to remember. See, any infant, a newborn, be it a preterm or a term, for the first 2 to 3 days, there is something called permeability, which means the proteins are capable of getting into the system intact. And after 2 to 2.5-3 days, this kind of permeability goes away and the junctions are meant to be a lot more tighter. How is this physiologically relevant? So when you give colostrum, mom's colostrum, the ready-made passive immunoglobulins from the mother are capable of entering the baby only because of this leak. Number one. Number two, the same leak goes away after 3 days for a bigger reason. Why is that? If the newborn system is getting exposed to foreign antigens, especially we are giving a non-human milk feed or some other bacteria, any other antigenic trigger which is not innate to the preterm baby system, it will be perceived as a foreign antigen and there will be an intense inflammatory reaction to it. So 2 days the logic is permeable to allow colostrum. Subsequently, since a preterm baby cannot have these as well developed as a term baby, non-human milk feeds tend to be damaging in terms of generating an inflammatory response. This is what we need to understand. Third one, obviously the enzymes, the protective agents like oligosaccharides and other things are not well developed. Another important clinically relevant point for maturity is the pH of the new preterm infant is slightly on the higher side. It is not as acidic as it should be. Now, everybody understands that the gastric acidity is an important component to prevent microbial translocation further down the gut. So if you cut off the acidity, it just makes the highway more clear for entry of bugs into it. So as it is, the pH is not great. Unjudicious use of antacids like Rantac and prazoles definitely makes matters worse and brings down the immunity. So please avoid using these things unless they're strongly indicated. According to me, 99% of the times I don't see any clinical indication for use of any kind of antacids in a preterm neonatal practice as such. The motility, again, it's not as fast as it should be. So the transit movement of the gut is so slow that if there is any kind of a fermentation or an infection within a particular segment of the gut, it is very unlikely to have moved away from that point out of the system. So all these things pertaining to the very immaturity of the intestines makes matters worse for a preterm baby. making him, more predisposed to the risk of NEC. Now, this is something very important and relevant. Dysbiosis. What do I mean by dysbiosis? Basically, it means that we have disrupted the normal microbiological environment of the preterm infant's gut. Why is it important? Now, if you see, if only a mother's milk is fed for the preterm neonate, over a matter of 4 days, the gut gets colonized with normal commensals, which are absolutely necessary for the improvement in immunity of the baby, because the commensal bacteria have some kind of friendly relationship with the gut mucosal barriers. If the same commensals are not to be fed, and let's say the baby gets a formula fed, you are more likely to introduce pathogens, number one. Number two, there is no scope for the gut maturity to actually get better from the immunological point of view, because we are not using commensals and pathogens are there in that place. This is where the logic of probiotics came into the scene. So understanding that, we gave a probiotic which replace in the place of commensal from mother's milk, you expected probiotic to make a difference. Again, at this point in time, even now at this point in time, the Cochrane says there isn't conclusive evidence as to whether it should be a standard practice. Why so? Because we are still unable to have some kind of a convincing evidence on which strain, what kind of dosing, and how to be given, so on and so forth. So the uptake or the practice of probiotic, given this as a background, is not uniform across units, is what I understand. Formula feeds. So a newborn preterm infant has to be fed. For a start, say for example, practices 10-15 years ago, we would always delay the feeds for first 3-4 days, and more so if there was a problem of any Doppler abnormality in terms of reversal of endosteric flow or absence of endosteric flow. As a rule, as a protocol, we would not feed them for 4 or 5 days. Now it is very clear that not feeding them, has got a bad negative impact on the baby's outcomes. So it is absolutely important to feed them, number one. But on day 1, obviously, if you're lucky, it's important that we give the colostrum as a smearing, and then expect the mother to give you some milk by day 2. But this may not be practical in most places. And here, I think if you compare, it is important that donor milk is given, again for the same discussion that you want to encourage the growth of commensal bacteria in the guts, in the preterm gut. And coming to the third point, the antibiotics. Invariably, I am not wrong if I say 95% of the babies would have probably gone on antibiotic if they are born at 28-29 weeks and they are ventilated. Now, the studies are very, very clear. If any baby who gets an antibiotic for more than 5 days in the first 14 days of life is likely to significantly damage the normal microbiota of the preterm. Why is that 5 days? It looks like there is some scope for redemption. Why do I say redemption? Because you may start antibiotic thinking there are risk factors. The point is, after 48 hours to 72 hours, if the baby has clinically looked well and the cultures are negative and none of the blood reports were suspicious for you, it's probably better to stop antibiotic. With the hope that this gut will cooperate with us a lot better going forwards. So dysbiosis and mucosal disruption is an absolute important event. The whole point here is these days we suffer from feed intolerance because we are feeding our babies antibiotics. So please use antibiotics judiciously. Feeds. As I said, mother's milk clearly scores our donor EBM, and then donor EBM way to scores our preterm formula. Now, if you look back at the pathophysiology, we were discussing that if you feed a non-human milk feed to a baby, the baby is going to react as if it is a foreign antigen. So there have been a lot of studies that have been conducted using hydrolyzed preterm formulas, saying, okay, if I use a pre-digested protein, something like a neocate or something, I'm more likely to not trigger off this gut's inflammatory response and kind of get the nutrition ahead. The logic is very good. So far, the studies have been compared between elemental, that is hydrolyzed protein feeds, and the mother's milk. Now, I don't think it even needs a study, according to me. It is a no-brainer that any day a mother's milk will score over any kind of synthetic milk we may produce for centuries to come. So the comparison between hydrolyzed protein formula and a milk, clearly mother's milk is good. But in a condition where mother's milk is not available, donor CBM is absolutely not available. If you want to compare between elemental milk feeds and preterm formula, I would probably go with elemental milk feeds. Again, there isn't any studies with it. Understanding the pathophysiology, elemental milk feeds makes sense, assuming that donor IBM is also absolutely not available and you're stuck. Otherwise, it is always donor IBM or preferable mother's milk. Rate of advancement. Over the last 10-12 years, I have given multiple talks on NEC, sometimes telling that if you go beyond 30 ml per kg, you are likely to increase the risk of NEC. Less than 10 ml per kg, you are going to be good. Again, I think all the studies merged together, there seems to be no convincing evidence in 2020 at this point in time whether fast feeding is going to accelerate the problem. The answer is actually no. So if you look at a baby and if you think he or she is going to tolerate feeds by going a little higher, you are welcome based on clinical grounds. I don't think you need to worry about, is it 20 ml per kg today, is it 30 ml per kg today? You just look at the baby and take a call, because the evidence does not support whether it is safe being at 10 or unsafe being at 30. No benefit in delay. Definitely, if you want to wait for another 2 to 3 days and think you're going to be nicer to the gut, it is to the contrary. You are going to actually cause a lot more trouble. Earlier, you're going to trigger off the stimulation to the gut mucosa with some milk. You're going to be doing well. Trophic feeds, I think it's a no-brainer, but by all means, please use colostrum, because as I said in the earlier part of my talk, colostrum really makes scientific sense when you have given it in the first 2 days, 3 days. After that, the junctions become tight and colostrum really doesn't get the immunoglobulin doesn't get access into the system. Am I being audible? Hello?
Sir, you are audible.
Yes, yes, sir. Yes, sir.
Yes. Because for a long time it looked like I was just talking to my computer. Right. What are the unproven risks? So all along the talk, I have kept telling it's an inflammatory disorder. It's an inflammatory disorder. It's something like a rheumatoid arthritis or a ROP or a asthma kind of a situation, which is exactly the truth. The primary infection, meaning a direct bacteria causing damage to the gut, causing necrotizing enterocolitis, has not been proven. But very small studies have identified few bacteria, especially a small study has shown Clostridium having colonized the gut, in which these babies developed NEC subsequently, and some have shown viruses. On this note, I would say be careful with cytomegaloviruses. I see that as a problem when babies start having feed intolerance. The baby looks well, it has reached a particular volume of milk, but then once they're into 60-70% of it, they start throwing up and misbehave. The gut X-ray looks all right, and for some reason this baby isn't tolerating feeds and it is not sepsis. Viruses can technically cause problems, especially CMV, because the risk of breast milk transmission is very high. So if a mother has had a very active or recent cytomegalovirus infection, I think it could potentially have some issues with feeding issues. And again, there are ways and means of combating CMV transmission, but that's not the scope of this talk. Circulatory instability. Again, it is pretty obvious that if a baby has hypotension, poor tissue perfusion, you would also expect that the mesenteric vasculature is also not going to be great. So as a result, consequent to the tissue hypoxia, you would expect the gut to underperform. It is a theoretical risk. Nevertheless, you've seen feed intolerance happening in babies who got bad hypertensions needing inotropic support. So you would exercise some caution when the babies are such sick. In fact, they say contraindicated milk if the baby is sick and on inotropic support. Now, anemia and blood transfusion. This again, people have been pretty much worried about not to give blood transfusion, rather not to feed a baby when the baby has a blood transfusion. The logic is, again, it kind of hampers the mesenteric vasculature during that time. It is not a very proven entity. The small amount of studies that are available, it depends on how you want to look at it. Some would like to believe it, some may not want to believe it. There are many units across the globe who kind of withhold a feed or two during transfusion. we don't do it. Especially, I think if the baby is feeding about 2 ml, 3 hourly, 4 hourly, something like that, it's not a big volume that is going to come in the way of anything harming the gut. However, if you look at anemia, so I think the earliest studies up until last year, I think you've seen that why there was an association between transfusion and feed is such babies were at risk of anemia, but if risk of NEC. But when we looked into the studies, we realized that most of these babies who had actually developed NEC had hemoglobin less than 7 or 8 gram%. So the logic seems to be that it is the anemia which is a risk factor for NEC, and the blood transfusion is just being a surrogate marker. And we've been looking at the wrong signal. So it is probably the fact that it is a severe anemia which predisposes the infant to NEC. Inflammatory response, again, just like the tolls which are creating a lot of trouble, it is the toll receptors which are there in the gut which become exaggerated and they start creating uncontrolled signaling. And this happens when they're damaged or provoked by an infectious agent or any kind of mucosal irritant for that matter. And then they start producing flooding of cytokines. Now, what are these cytokines? Especially these cytokines which get released in this gut system, is they're capable of self-damaging their own property. Now you have IL-1, 8, 12, 10, things like that. So they are misguided, overreacted, excited systems, molecules which kind of damage the gut and make it more susceptible. And then that leads to cellular necrosis. I think I will leave it at that. The point here is 3 things. 1, the immaturity of the system. With the prematurity, you can't do much about it. So we have to accept the fact that the baby is premature and take it from there. 2, I think the dysbiosis is extremely important. Try not to hamper the intestinal environment as much as possible. Try to cut off antibiotics as early as you can, if the clinical condition allows you to. Just don't convert. Let's make it 7 days. Let's give it for 10 days, just for the sake of safety, because you may keep safety on mind, but you are going to definitely fall on the fact that this baby is not going to be tolerating feeds going forward. Please remember the fact that NEC can have a complication with infection. So as a result, we'll need antibiotic, but the NEC per se has happened because of an exaggerated inflammatory response secondary to some triggers. Trigger could be an infection. It could be a non-human milk feed. So as far as possible, strictly, please go towards mother's milk or a donor IBM, and as much as possible, avoid formula feeds. And again, with formula, I've said if it is inevitable, there is a very small scientific role of hydrolyzed protein milk feeds at this point. So I think I will stop here, and I think allow Dr. Raghavendra to talk on clinical features and further management of it. If there are any questions, I think maybe we'll be taking at the end of the talk, I believe. Thank you. Thank you for your patient hearing.
Sir, our senior Lakshman Bidri sir has joined. So he just wanted to, have few words.
Yeah. Good evening, sir.
Bidri sir.
Meanwhile, Raghavendra, you keep your slides ready.
Yeah.
Sir, Dinakar sir, are you hear us?
Share my slide.
Yeah, please talk.
Yeah.
Sir.
Okay, Dr. Pani.
Hello.
Yeah. See, your talk was very good. Excellent.
Thanks, Dinakar.
Yeah, excellent. But the thing is, I think so. Host is muted my video.
No, man, I can hear you. Oh, video.
Okay.
Yeah, I can hear you though.
That's good. But the hydrolyzed formula, there is a something, because many people are watching you. Okay, more than 300 people are there. I think so.
Can I make that stand very clear once more, please, so that it doesn't give a wrong message out there?
Because hydrolyzed formula, you told there is something, but I think so. You just, when the question comes to you, please answer it, make it more clear. Because
yes. If nobody is asking, I might want to just address it anyway. So let us see if somebody is going to come up with that question.
Yeah, please. Later. Dr. Raghavendra, are you ready, sir?
Yes, sir, I am ready. Sir, good evening, sir.
Good evening. Good evening.
I thank one and all for participating in this evening session. I thank all the office bearer of NNF for giving me opportunity to speak on the management and prevention of necrotizing enterocolitis. Thank you, sir. Coming to necrotizing enterocolitis, it is one of the surgical emergencies which we anticipate in the preterm babies. As you know, it's a gastrointestinal surgical emergency. As you know, 30% of our newborns admitted in our NICUs are preterm babies. Almost near 5 to 10% of these babies will anticipate this type of necrotizing enterocolitis problem. So we have to be very cautious in dealing with these babies. So the necrotizing enterocolitis is also inversely proportional to the gestational age. As you know, lesser the gestational age, more the have to be very cautious when you are managing any preterm babies. So coming to the pathophysiology and clinical features, already our Phanibushan sir has briefly told about the pathophysiology. Let me come to you regarding the medical management. So what are the medical management which you need to do when you are dealing with the necrotizing enterocolitis? The most therapeutic option of NEC are aimed at treating the disease process once it sets in, and also the limiting the progress of the disease. Please remember, you should be always be suspicious when you are managing a preterm babies. Please remember that this is usually necrotizing enterocolitis sets in during the second week of admission of a preterm babies. Remember, it can extend up to the 3 months, and even 90% of the babies less than 32 weeks have this necrotizing enterocolitis issue problem, and 10% will be the term babies. So coming to the next management, so management is based on the modified well staging criteria. So remember, it is associated. Then whenever you are dealing with the necrotizing enterocolitis, you have to do a full evaluation. So you have to work up the baby properly, look for any infectious cause, thorough radiological examination you need to do, and laboratory values has to be properly monitored regularly based on the instability of the baby. Next, parental antibiotic, as already told, whenever you admit any preterm babies, you already would have started on parental antibiotics. So parental antibiotic also had a role in managing this NEC. So again, when diagnosis NEC is considered when it crosses the stage 2, parental antibiotic is mandatory, and it is and you definitely you need to give a bowel rest in managing this case. So how you manage methodically, I'm going to explain properly. So immediate medical management when you are dealing with the NEC is therapy is based on intensive care measures. So always you do methodically and anticipate the potential problem. So as you know, some of the when baby is more lethargic, when baby is having temperature instability, when there is when baby has persisting abdominal distension, pre-feed is more. So then you have to anticipate these NEC like problems. So coming to, you have to have a multi system examination when you are managing the NEC. Please remember, when you are managing any respiratory things, you have to properly assess the ventilation status of a baby. You have to do a thorough physical examination, look for blood gases, and if there is need for any oxygen supplementation or mechanical ventilation, you need to give. Coming to the cardiovascular system, you have to assess for a circulatory status of a baby when you are managing a NEC. Look for a proper physical examination, check the blood pressures, look for the volumes. If there is any hypovolemia or baby is in any septic shock, you need to supplement the saline. If there is any need, any deranged PT, APTT, go for a FFP. And if baby has a low perfusion, then you think of going for a low dose dopamine, which has a role of increasing the planchnic and renal blood flow. Coming to the metabolic functions, once these babies go for a metabolic derangement, there will be a severe metabolic acidosis. Just you need to do a volume expansion, and again there is a role of bicarb if required. Look for a pH and lactate levels, serum electrolyte levels, and liver function has to be monitored properly. Blood glucose level has to be monitored on and off required. Coming to the nutrition, please remember, once you suspect the necrotizing enterocolitis, you have to discontinue the GI feeds. You have to decompress by suctioning to the nasogastric tube. And you have to start a parenteral nutrition. If there is any central line, you have to remove it, go for a peripheral line. And your aim should be providing 90 to 120 calories of calories per kg per day. You have to start an amino acid solution and lipid solution as when targeted. Coming to the infectious, always be suspicious that if baby has any infectious causes. So go for blood, urine and stool culture and go for its sensitivity. Antibiotic is adjusted according to the cultural report. Please remember, it should be a multi polymicrobial approach. You have to cover gram positive, gram negative and anaerobic cover as and when required according to the culture sensitivity. So usually treatment is generally maintained for up to 14 days according to the staging guidelines. Coming to the hematological aspect. So let me be clear, you have to go for a thorough hematological examination, go for a complete blood count and differential count, go for a blood smear and look for the triad of NEC, thrombocytopenia, hyponatremia and metabolic acidosis. Please correct accordingly. If there is a need for platelet transfusion, if there is severe thrombocytopenia, go for that. And packed blood cells, you have to maintain a hematocrit more than 35. And fresh frozen plasma has a role when there is a derange PT, APTT and coagulation profile delay. So coming to the renal functions, always keep a watch on the renal functions. Check for creat level, electrolyte level and blood level. So if there is any impending respiratory failure like going for a acute tubular necrosis or coagulative necrosis or any vascular accident, according to that you have to maintain the fluid therapy. So coming to the neurological problem, one must be alert of the problem associated with the managing the NEC babies. So they are more common for meningitis and intraventricular hemorrhage. So seizure should be always be in your background, manage according to the requirement. So always anticipate the complication and promptly recognize and treat the baby. Coming to the GI function, what I have told, always keep the baby nil per orally and assess the baby girth, abdominal girth. So always remember, once there is a abdominal distension, decreased bowel sounds, always keep a watch of the signs of perforation. If there is any perforation or full thickness necrosis or signs of peritonitis, then immediately you have to manage medically. And if there is any signs of perforation, if baby is having a worsening condition, then there is a need for surgical intervention, which I will come later. Coming to the family support, remember family support is important whenever you are managing a sick baby in your NICU. So these babies, always parents will be more anxious. You have to explain them properly and you have to take their confidence and you should have a trusting alliance with them when you are managing this necrotizing enterocolitis baby. So coming to the modified well staging of necrotizing enterocolitis. Remember, we have this staging is done according to the severity, stage 1, stage 2, stage 3, again divided into A, B, and according to the severity. Stage 1, there will be temperature instability, apnea, bradycardia, and abdominal signs will be, there will be gastric retention, abdominal distension, emesis, and remember, heme positive stool will be there in a stage A. Radiological sign will be, there will be normal intestinal distension will be there, and you, in these cases, you have to keep the baby NPO, suspect NEC, and give antibiotics. So coming to stage B, again, there will be a grossly bloody stools, as if it is an interception like picture. Again, here also you have to keep NPO and give antibiotic for 3 days. Coming to stage 2A, there will be an absent bound sounds with or without abdominal tenderness. Here there will be a
Not audible now.
Here there will be some of the other radiological signs will be intestinal dilatation and pneumatosis intestinalis. Please remember, stage 2A will have a pneumatosis intestinalis like picture. So again, here you have to keep NPO and you have to give antibiotic for 7 to 10 days. Coming to stage B, they will have a same feature as above, but there will be an absent bowel sounds, definite tenderness will be there, abdominal cellulitis or right lower quadrant pain will be there. So again, radiological sign will be, there will be a ascites and portal venous shadow will be there. So again here, management will be, you have to keep NPO and you need to give antibiotic according to the culture sensitivity for 14 days. And again, coming to stage 3A, it is an advanced severe illness where there will be bowel will be intact. So baby will have a severe hypotension, bradycardia, apnea, and respiratory and severe metabolic acidosis. These babies will be going for a DIC like picture. So what are the clinical features is same as above, but there will be a peritonitis like picture, marked tenderness will be there, and there will be abdominal distension. In a radiological, you have to look for a ascites like picture. And again, the management will be safe. You have to give an antibiotic, keep baby NPO. You need to give inotropic support, ventilator support, and if there is need for paracentesis, you have to go for it. Coming to the last stage, which is a severe stage, where baby will have a severe perforated bowel. These babies will have a radiological picture of pneumoperitoneum. So here there is definite role of surgical line of management, and you need to be very alarming whenever you are managing such cases. So these are some of the radiological findings which you will see. Hematosis interstitialis, as you see, it is stage 2A, portal vein gas again stage 2B, and pneumoperitoneum, which will be in the stage 3. So this is a static blue picture, which is erect abdominal X-ray, which was taken on day 2 and day 5, and this is a intestinal gangrene and perforation, which you will see in the stage 3B. So next is proposed antimicrobials when we are managing the NEC. So remember, it's a polymicrobial approach. You need to cover the gram-positive, gram-negative cover. You need to use some of the antibiotics like ampicillin, vancomycin, gentamicin as and when required according to the culture sensitivity. And there is a role of metronidazole if there is a perforation, and clindamycin has a role whenever you need to cover the anaerobic enteric organism. Coming to the surgical intervention, please remember there should be a prompt consultation should be obtained from the pediatric surgeon whenever you are suspecting a NEC-like picture in your baby. Remember, GI perforation is definitely an indication for intervention whenever you are managing NEC. Perforation occurs usually in 20 to 30% of the cases, and usually 12 to 48 hours after the onset of NEC. And in fact, and always keep a suspicion that whenever you are managing the baby in stage 2B, when there is an increase in the abdominal distension, abdominal mass, or worsening clinical picture, despite medical management, and if there is any persistent fixed loop is there in the radiograph, and if they have may have a perforation like picture, definitely there is a role of a surgical pediatric surgeon, and there is a role of operative intervention at that stage. Coming to the mainstay of surgical treatment is resection with enterostomy by laparotomy. So peritoneal fluid has to be examined for the infection, and it should be sent for culture. Remember, necrotic bowel is resected and sent for pathological examination according to the requirement, and viable bowel sites are exteriorized as a stomas. So if there is extensive involvement, baby is worsening, even the second look operation has to be done after 24 to 48 hours. And peritoneal drainage is other alternate whenever you are dealing with such stage 3 baby. When baby is extremely low birth weight babies, when there is weight is less than 1,000 grams and babies are extremely unstable, that is the time when there is a role of even peritoneal drainage. Recent RCTs has shown that there is no much difference between managing the baby with the laparotomy or peritoneal drainage. The outcome is same. There is no much difference. Survival duration of stay in the NICU and length of hospital stay is almost similar whenever you are managing such cases. Coming to the prevention of NEC, which has to be given more importance. Remember, there are more of RCTs which have been studied for prevention of NECs. So the RCTs which is having grade 1 and highly recommended is first is antenatal corticosteroids. So administration of maternal antenatal corticosteroids definitely has a very good benefit whenever you are managing the NEC. There is a definitely decrease in the incidence of NEC. So many controlled RCTs have been done with Roberts Dalizal, who have shown that the babies which mother has given antenatal corticosteroids, there is definitely reduction in the risk of NEC. So again, administration of maternal antenatal corticosteroids for a threatened preterm labor has now become a standard therapy for the benefit of the neonates. So again, next recommendation is tropic feeds. Remember, gut priming, what we call in our NICU. Tropic or non-nutritive or priming gut is initiated as early as possible in these babies. What exactly they do is they induce the enzymatic activity. They will definitely has a benefit role in managing this NEC. This Bharat et al. Has done a lot of studies on tropic feed. What he has come out with is definitely there is a lot of benefit when you are managing a baby with tropic feeds. And early introduction and a small feed. Non-nutritive feeding has definitely a role in preventing the NEC. Coming to next preventive strategy is as the will contain maternal IGF factors, endodermal growth factors, and prebiotic elements, BAF. All these are definitely has a role here to keep the gut healthy in a newborn. So these Lucas and Cole has performed lot of studies using formula milk and the breast milk. What they have come up with is the babies which are fed with the breast milk has more benefit, almost like more than 6-fold more benefit in preventing the NEC. The risk of NEC is almost come down with the breast milk admission. Next is oral antimicrobials. Basically, the pathophysiology of NEC has already, Phanibushan sir has told, there is evidence of the bacteria which are non-commensals. So these oral antibacterials have also been tried, but that is not very benefiting for the babies. Recommendation is very low. It is D strategy. So oral antibacterials have been also been tried in managing or preventing the NEC. So coming to probiotics, so the probiotics is also upcoming very promising in managing the NEC. These provide benefit to the preterm by enhancing the mucosal response, improving the mucosal protective barrier, increasing the production of anti-inflammatory cytokines, decreasing intestinal bacteria permeability, and competitively excluding the pathogen microbes. These are some of the mechanisms by which probiotics act on the neonatal gut. Studies have shown that supplementation of probiotics like bifidobacter, lactobacillus, or saccharomyces have definitely shown reduction in the incidence and severity of the NEC with very few adverse effects. So most studies have utilized various combination of bacteria, but still there is no standard guidelines in managing or appropriate use of probiotics. So this has to be thoroughly studied, and the proper dosage has to be come out with a lot of studies. So again, next is the role of prebiotics. Prebiotics has no much role, but again, if they have studied a lot in the animals, but final outcome in the adults is very less. So what they have seen is supplementing of prebiotics at the end of 7 days. What they have seen is bifidobacteria in the stool was determined to be significantly higher with the use of prebiotic in the animals. Conversely, the non-commensal like E. coli and enterococcus number has definitely come down in managing this using with placebo. So some of the other modalities which they have used in used for managing and preventing the NECs are like superoxide dismutase and N-acetylcysteine. These are the antioxidants which are used to prevent the NEC, but these don't have much role. Again, coming to the epidermal growth factor supplementation is were also promising in the animal model, but in the humans there is no much improvement. Coming to arginine, which is a vasodilator, this is also very promising potential agent for prevention of NEC. What exactly it do is it causes the reversal of vasoconstriction induced by nitric oxide deficiency in a preterm infant. So again, oral IgG and IgA has been tried, but it is also not more promising. So remember, those are all the preventive strategies which were used in managing the NECs. So first three, whatever I have discussed, like tropic feeds, breastfeeding, and those are very promising in managing and preventing the NEC. Coming to the early complications. So what are the early complications you expect when baby go for a necrotizing enterocolitis? Remember, mortality stands somewhere between 30 to 60% in the NICUs. Stricture formation will be there for 25 to 35%. Bowel obstruction will be there for up to 5%. Enterocutaneous fistulas will be there. Failure to thrive secondary to short bowel syndrome and malabsorption will be there. TB and related cholestasis is again one more problem when you are managing the NEC. And central line sepsis. Please remember, central line has to be removed as early as possible when you suspect the NEC.
Raghavendra, just speak louder, no?
Yeah.
Louder.
Yeah. So again, the late outcomes associated with the necrotizing enterocolitis is, remember, this is one of the second most common cause of morbidity in the preterm unit. These morbidities are primarily for short-term and long-term GI problems. Coming to GI morbidities, remember, failure to thrive due to malabsorption, bowel dysfunction, and long-term usage of parenteral nutrition. These are all causing a lot of issues like cholestasis. Liver failure is again one more long-term complication with this necrotizing enterocolitis. Again, one more adverse neurological sequelae which you are seeing in this surgical intervention baby versus medical is these neonates with NEC have at least 20%. In one study, they have told that up to 20% has developed cerebral palsy, and 3% has visual impairment, and 3% has hearing impairment, and 30% have cognitive impairment, and again 35% develop psychomotor impairment when they have managed with the surgical things. So the rate of impairment is much higher with this necrotizing enterocolitis baby when they have managed with the surgical intervention. So remember, even not only GA morbidities, neurological sequelae is also more in when you manage the babies of NEC with surgical intervention. So remember, surgical, one study has shown that surgical NEC carried the increased risk of cerebral palsy and psychomotor impairment compared to those with managed with the medical management. So surgical NEC definitely will have a very bad outcome in a GA morb with the GA comorbidities and neurological sequelae. So coming to my summary of my slides, I just want to say that necrotizing enterocolitis is a primary disease process of a GI tract of a preterm neonates. Remember, it constitutes almost 18% in the neonates and 10% in the term babies, and it is definitely inversely proportional to the gestational age. And it constitutes about 1 to 5% in any NICU, and 5 to 10% of a very low birth weight babies. Clinical manifestation with the NEC is very vague. Please remember, always keep very suspicion whenever you are managing any newborn low birth weight babies. Usually this happens in a second week. Please remember, second week up to 3 months, we have seen the babies with necrotizing enterocolitis. Always be suspicious whenever a baby with apnea, desaturation, bradycardia, lethargy, temperature instability. Always look for GA symptoms like feed intolerance, emesis, bloody stools, abdominal distension, tenderness, and abdominal wall discoloration. Always be suspicious with these signs and symptoms in managing the NEC. And coming to the medical management, typically, as you know, complete bowel rest and decompression is mandatory, and antibiotic therapy is required according to the culture sensitivity, and other hematological abnormalities or electrolytes or any fusion deficit has to be corrected, and respiratory and cardiovascular support has to be done as and when required. And surgical intervention is mandatory whenever you are dealing with a stage 3 baby. And remember, prevention has definitely grown by using the breast milk, early initiation of tropic feeds, and judicious advancement. Remember, judicious advancement of enteral feed is very important whenever you are managing any postnatal in preventive strategies. And other things are like oral antimicrobials, antioxidants, and supplementation of arginine are still in the studying phase. And recent promising data is something regarding like use of probiotics, but still there is no definite guidelines are there. So let us wait for the other few studies where they will come up with the definitive studies of use of probiotics in managing the NEC. So thank you one and all for giving me this opportunity. So I have covered the management and preventive strategies of necrotizing enterocolitis. Thank you. One and all.
Dr. Prashanth?
Yes, sir. Yes, sir.
Yeah. So, behalf of Dr. Raghavendra.
Yes, sir.
Okay. Raghavendra, please, for all the next speakers, and to Raghavendra and everybody. Raghavendra, you are there with us, sir?
Yeah, I am there, sir.
Can I see you, sir?
Yes, sir.
Okay, Raghavendra, you are not at all audible, number one, sir. Because you are talking very away from your laptop. Because almost 32 members have left telling that you are very away. It is echoing. Next time, whenever you come, sir, you should see yesterday. So Dr. Guru Prasad sir was very loud. He was very near to the mic. He was not bothered about anything. He was bothered about his voice. What everybody was audible. You are not very away. 41 people have messaged me, sir. You know why? Because why I am telling you, sir, directly.
Okay, sir.
Because next speakers, everybody is online. Everybody should know, sir.
Okay.
Because volume is more important. Because whatever you are telling, it is coming in the screen, sir.
Okay.
Please, sir, please, because otherwise it will be very difficult.
We'll take care.
Because you are concentrating on reading, sir.
Okay.
Thank you, sir. Next, Dr. Prashanth, sir.
Okay, Prashanth.
I think everybody is
next, sir, Dr. Prashanth, sir.
Yes, sir. Yeah, I think yeah, we'll mute all now. Am I audible now? Is my voice clear?
Yes, yes, clear.
It's clear, no? Okay, okay.
Yeah.
Yeah. So good evening, everyone. So this is the traditional part what we have learned so far when it comes to NEC, knowing about the predisposing factor, pathophysiology, and the management of NEC. So what I'm going to talk now is the introduction of ultrasound in the detection of NEC by neonatologists, like how we had the echo, we had ultrasound, and when it comes to lung and other things. So NEC, how best it is, how good it is when compared to X-ray, and how we can get deceived by X-rays, and with very minimal features what we see in X-ray about staging, and even how it can have impact on management with the case scenario. I will be explaining in detail. So next thing, one second. So when it comes to NEC, diagnosing where we stand, whether it's in early part of the process or disease or the late part, because medical management and surgical management, there is a very thin line. So whenever we give a pediatric surgeon, unless we have a proof of a dead gut, and unless we remove the dead gut, the problem is not going to get solved. So we need to have a what stage of disease the NEC is in. So that we can see live by doing an ultrasound abdomen. So like any other in medical thing when we do, the most basic thing of any pathophysiology or anything what we do is anatomy. So when it comes to gut, anatomy of the bowel is very important. What we have in gut, we have small intestine and large intestine. We have colon, jejunum, and ileum. So most common site is ileocolic junction, where we see the part of bowel getting necrotized. So ultrasound has got many major advantage when it comes to when we compare it to the X-ray, especially in terms of diagnosing. So we need to have a brief awareness about watershed areas, so hepatic flexure, splenic flexure, the rectum, and the terminal colon. This is the place where we have dual supply of the blood supply. Basically, watershed areas where the part is supplied by two separate arteries. Even if there is compromise in one artery, the other arteries will try to give good perfusion and maintain the perfusion, and will not allow the tissue to die. So these are the watershed areas. When it comes to intestine, we spoke about the anatomy. When it comes, we have small intestine and large intestine. So how it looks, especially, and what are the things which we need to, key things, what we need to remember when you're holding a probe and doing an ultrasound in an NEC baby. We see, when you put a probe, we see a layered appearance, easily compressible. We see a good intestinal motility, peristalsis, a nice, punching in, punching out of intestine. Then the thickness is what we observe, the thinness what we observe, and we see if there any associated fluid in the ultrasound when we put a probe. Coming to the anatomy, the upper half of the abdomen is jejunum, the lower half is the ileum. This is how we approximately, we divide. So when we start ultrasound, we usually start with the right iliac fossa, then we go up to right upper quadrant, then the left upper quadrant, then left lower quadrant, or you can go in the shape of a snake, in a zigzag pattern. So whichever pattern you use, we need to have a brief idea about how the bowel looks when you put a probe. So when you look at the bowel of both jejunum and ileum, they are basically majorly differentiated by plica circularis. This is the folding of the mucosa within the intestine. So you can see, I've put a picture, where the jejunum has got plica circularis, and this is the plica circularis. And then we can see in ileum, it is completely smooth. So these are the two different pictures what I've put here. One is how it looks, the jejunum, how it looks, and the ileum. In ileum, you can see it's a very smooth, plus you see multiple layers from inside to outside. Is my cursor visible? Visible?
Yes, yes.
So you can see the layers of the ileum, and the smoothness what you can see when we put the probe. So this is the video of how exactly it looks in ultrasound. This is plica circularis, what is marked in the hand. And you can see a nice motility of the intestine. You can see there. So this is how the jejunum looks. So when it comes to ileum, in a transverse section, when you take, it's a very smooth and a round without any circular, plica circularis within the picture. Colon, we all know that anatomically it has got haustras from inside and outside. And when we go with ultrasound, you can clearly see the haustra within the loop. And this is the normal bowel looking loop. And you can see here, you have certain, normal looking bowel with good intestinal motility, and multiple loops you can see here. Because since just to give an idea, because I'll be explaining everything in detail step by step. So just to get an idea before I explain that how exactly it appears when we look into the ultrasound, So when we talk about X-ray findings, we have in X-ray very difficult to find pneumatosis intestinalis, portal venous gas, and the perforation. So these are the three major findings what we look at. But when we talk about ultrasound, we have 12 features. When you put a probe, one is you are seeing the first and major advantage of ultrasound is you will see the layers of the intestine. That is a major advantage. You can see live status of the mucosa. You can see live status of the intestinal motility. We can see the live status of gas within the mural air. You can see the complex fluid if there is any associated ascites or infected fluid which has been spilled over into the abdominal cavity. Portal venous gas is easily seen. Not just you have to look at the web-like structure in the X-ray. It is you just put a probe. Unless you are blind, you will not miss it. It is so very, very, very clear. And even thickness of bowel, thinness of bowel. So in the early part of the disease, you see there will be thickening because of the inflammatory process and increased blood supply. So when you put a Doppler, usually 3 to 9 color Doppler spots in the transverse section of the intestinal muscle layer. That is the normal what we see, and there are different patterns which are abnormal. So that I'll be discussing. Plus, intestinal signature is nothing but the layers of intestine. We have mucosa, submucosa, muscularis propria, and serosa. So these are the layers which we can see. So that's the reason why if you use high frequency probe, you can clearly see all the layers of the intestine, and which will be the first marker for you to understand whether the inflammatory process is set in or not. Next, coming to the superior mesenteric artery diameter, what we look at, and velocity of the superior mesenteric artery, what we look at. Than 10 megahertz with curved, with warm gel. You have to be gentle, and you have to follow all the regular protocols when you hold a probe. Hygiene, cleaning up the probe, universal precaution needs to be done. And most important things, have a close look on the vitals as well. So that should not be forgotten. So we cannot just do an ultrasound on a dummy baby, because we'll be doing on a live baby which has got pain. So you have to be very sensitive and very, very soft touch and warm gel. Make sure that baby is comfortable and you are also comfortable, and you'll be visualizing and trying to understand what stage of pathology is going on, whether pathology is there of NEC or not. Now, as I said, this is one of the way where you can start from lower quadrant, then you go with right upper quadrant, then left upper quadrant, then left lower quadrant, or you can go in the form of zigzag, So peritoneal cavity, we see a fluid, as I said, fluid, free air, and pneumatosis intestinalis, and this. So first major advantage, as I said, of abdominal ultrasound in NEC is we are able to visualize the status of the bowel wall, bowel thickness, echogenicity, and peristalsis. So I'll be telling you how it is. So when we talk about intestinal signature, this is what exactly it looks like. From inside to outside, if you take from the lumen, we have mucosal interface, which is echogenic. Then you have mucosa, which is hypoechoic. Then you have submucosa. Then you have muscularis layer, and then serosa. In this, if you clearly observe, there are two layers which are hypoechoic. One is the mucosa, another one is muscularis propria. The two M's are hypoechoic. Rest all is echogenic. So you get white, black, white, black. This is called intact intestinal structure. Just give me a minute, just 1 second. I'll be back. Just 1 second. Yeah. So this is how the intestinal signature looks like, because it is very important for us to know this, and this will give us a clear idea. And I'll be putting a lot of videos ahead where you get a clear idea about what is a healthy intestinal structure, what is an abnormal or pathologic intestinal structure. So this is the video which you can see how exactly it looks in the video. So you can see, can anybody put it in a chart box whether it is ileum or jejunum? What is it? Can anybody put in the chat whether it is ileum or jejunum? Yes, ileum, correct. So it has got inner smooth. You got there is a bowel within the thing, and you can see the layers of bowel structure. So these are the layers which you need to remember. As I said, from inside to outside, if you go, mucosal interface, mucosa, submucosa, and muscularis propria and serosa. Mucosa and musculosa are black in color, nothing but hypoechoic. Rest all is white. So it starts as white, then black, white, black, like that layers it starts. Now, if you go into pathology, this is how exactly it looks like. Mucosa, submucosa, and muscularis propria and serosa. Then this is another photo in a transverse view, and even in the longitudinal view, how the layers of the intestine looks like. You can see in the longitudinal view the layer of white, black, white, black. This is called intestinal signature. So this has to be intact. So if there is any inflammatory process, you see loss of intestinal signature. This is the pathology of normal versus abnormal. You can see normal where beautifully you can see the all the layers of intestine, and when it is necrotized, this is exactly how it looks like. So in ultrasound, we see this as altered intestinal signature with sloughing of mucosa, and this is live dead gut. You can see clearly how it looks like within the tummy of NEC baby. Thickening and thinning, ideally, normal size of the intestinal mucosa should be between, the intestinal layer thickness should be around 1.3 to 2.6. If anything more than 2.6, if anything less than 1 mm thickness, it is called thinning. Anything more than 2.6, it is called thickening. So this is another criteria to get an idea about the status of the intestine. So you can see a bowel wall thickness here. It has been marked with asterisks in the first picture, even in the arrow. In all the 3 pictures, do you see intact intestinal structure? Okay, you can put it in the chat. 1 second. So you can clearly see that there is loss of intestinal signature. Yes. So it is not something which is very difficult. We as a neonatologist, after knowing pathophysiology, predisposing factor, management, and side effect of each drug, just to hold a probe and put it, and then look for this simple structure, because this is going to tell us exactly that what we are dealing with, what stages of inflammatory or what stages of NEC we are in. So this is how exactly it looks like. So when we talk about thinning of the bowel wall, these are the pictures which clearly depicts thinning, complete thinning of the intestine. Exactly, it looks like thinning, and even the effusion, complex fluid outside the bowel, you see septate, exudate fluids, even that can be noted. So pitfalls. So when we talk about pitfalls, how does nematocyst intestinalis look like? And with absent or ineffective peristalsis, at times what happens is when you put a probe and you see on the right side how sluggishly the intestine is moving. That is moving with respiration. It is not contracting. There is absent bowel peristalsis. If there is a peristaltic movement, you see a very active bowel movement which keeps on pumping in, pumping out. So if there is pseudo peristalsis or ineffective peristalsis, this is how exactly it looks like. I'm sure you got an idea how to differentiate between jejunum to ileum and what is effective peristalsis, what is not effective peristalsis. So this is the video which suggests how exactly the pseudo or ineffective peristalsis looks like. So if there is an effective peristalsis, you see complete pumping in and pumping out. It will be quite active and healthy, and you see at least 9 to 10 peristaltic movement per minute. So when we talk about luminal air, which one of the X-ray finding, where you have to literally search. If the X-ray quality is not good, you really find it very tough, or if there are any artifacts. Yeah. So when we talk about pneumatosis intestinalis, when you put a probe, you will not miss, and you can see a white dot within the muzzle layer. Are you people able to see the white dots? You can just drop it in the chat box. Sorry. So, and one more thing is you can see the reflection. This is called posterior reverberation. So I'll tell you the importance of this. Suppose if there is calcification of intestinal wall, and then there is pneumatosis intestinalis. So when you put a probe, you get air appears white in ultrasound. So you can see a streak of the white dots within the lumen layer. So if it is a calcification, you don't see this posterior reverberation. If it's air is there, pneumatosis intestinal PI is there, it looks like you get posterior reverberation and white dots. So you can see multiple, all A, B, C, D picture, you can see there are white dots. This is nothing but pneumatosis intestinalis. In X-ray, you have to literally struggle, and it all depends on how they take the X-ray. In ultrasound, nothing, just take a probe, put it in the abdomen, you will see beautifully all this feature. This is calcification versus massive pneumatosis intestinal. Get that. First, to start, as I said, just getting the image of each intestine, trying to differentiate between jejunum to ileum, colon, and trying to identify the intestinal signature is more important. So as I said, calcification and PI, posterior reverberation goes in favor of pneumatosis intestinalis. Calcification, you don't see that posterior reverberation. How to differentiate between the pneumatosis intestinalis, which is there within the muzzle, within the intestinal layer, versus inside the lumen. So when you compress or when you change the position of the baby, you see, and I will put that video as well, you will see the pseudo PI will keep moving and disappearing when you change with every peristalsis, with every pressure or position when you do it. Now, this are people able to find out portal venous gas? You can see here, but it's so difficult, very, very difficult. Unless we closely look into that, you will get an idea about this. But when it comes to the ultrasound, and there are very few in number which will be detecting. But when in ultrasound, this is the portal venous gas. You have to just put a probe over the liver. You will not miss unless you are blind. You can see multiple dots, and even when you put, you can see the that from the main portal vein to the periphery of the portal veins, you can see the bubble moving. So that is how it looks like. It can look like linear pattern, and it can disappearance. I think we're not going to depth of the thing. First, let us identify that. If there is disappearance, does not always mean that there is a clinical improvement, but this is one of the signs to classify the staging of NEC, and that will have impact on the management, whether to go for early medical management or the surgical management. And even when you put a Doppler, you can hear that, like that sound, like how you hear the heartbeat, you hear the movement of air bubble within the portal vein. So that is the beauty of ultrasound. So this is how it looks like. You can see multiple pictures I'm putting here. You can clearly see this linear pattern of white dots within the portal veins. This is how, I'm sure the image is very clear for the audience participant. This is how exactly it looks like. There is a thick arrow which is marked white. That is the thing which will show, that is showing basically the movement of air bubbles within the portal vein. So it can be a punctate or a linear hypoechoric area. As I said, just take a probe, put it over the liver. If there is portal venous gas, you will not miss it. And even you can see the portal vein gas bubbling and moving from main vein to the periphery. This is how exactly it looks like. Two pictures I have put. When it comes to abdominal fluid, there is even you can actually see because of the inflammatory process. If the fluid has fallen into the abdominal cavity, whether it is transudate or exudate, you can actually get an idea about that. So if it is exudate thing, you get hyperechoic plus septate, and it's a dirty looking basically. And with along with other features, you can easily correlate about the changing of NEC. The second major advantage, as I said, compared to X-ray, is you can see fluid, whether it is intraluminal fluid, extraluminal fluid, where exactly fluid and what type of fluid it is. So picture A, I've put the first picture, inflated and septate, which is hyperechoic. And can anybody tell me the second picture where I've put the loculated, the septated fluid, whether it is jejunum or ileum? What is it? The second picture, jejunum or ileum? Is my voice fine now? Jejunum. Yes, yes, yes. Because there is plica circularis which is there. So it is so easy. And you can see outside the peritoneal cavity. So, I think a few of them have their audio. Yeah. Right. Yes. I hope it is fine now. Yeah. Yes. 1 second. So free fluid. Yeah. Free fluid abdominal gas, the anterior surface of the liver, I mean the bubble which I was talking about, and the how pneumatosis intestinalis looks like. So I put a lot of how the septate looks like. All right. Yeah. When we go with bowel wall peristalsis and bowel wall Doppler, as I said, around 3 to 9 color Dopplers what you see. And this is how exactly looks like the color Doppler. The first picture normal, where you have around 8 to 9 normal dots scattered. There is no specific pattern over here. Suppose if you don't see any Doppler, it is showing there is ischemia. That is one thing. The second thing is it is into the going into the advanced stages, or it has already perforated and bowel is completely gangrenous and it is dead. The second picture, the third and fourth picture, you see different pattern. There is a circular pattern like a whirlpool. There is a Y pattern. There is a zebra pattern with different colors. These are all abnormal Doppler findings which you specifically see in NEC. And based on that, staging also varies. So when we talked about bowel wall thickness, anything more than 2.6, anything more less than 1. These are all the thickness, different patterns which I have mentioned: Y pattern, zebra pattern, whirlpool pattern, circular pattern. These are all abnormal. So this is the Y pattern which I've already put. This is the ring pattern. Very easily you can make out. Put a color Doppler, and you see how the pattern it looks. Capture it and slowly observe. Not just in one place. Try to start with lower quadrant, right lower quadrant, where ileocolic junction is there, and then you move across all the thing. Everywhere you do, look at the intestinal signature, peristalsis, and get a Doppler done. This is how it looks like. This is the zebra pattern. I'm sure. Can anybody tell me whether it is jejunum or ileum? The first picture. Jejunum or ileum? Yeah. Correct, jejunum. So I'm sure most of the participants are already have become expert in terms of differentiating what type of lumen, whether it is jejunum or ileum. Excellent. So this is how exactly it looks like. This is the Doppler of NEC baby and how exactly it looks like. So there is necrosis, there is no perfusion. You can see a specific pattern. What You can put it at the chat box. Yeah, correct. So it is abnormal. This is how the process happens. First, there is a normal looking bowel with minimal Doppler, around 3 to 9 Doppler dots. You see the inflammatory process has set in. There is increased in Doppler, which might have take a shape of circular Y pattern or zebra pattern. Basically, it suggests the increased hyperemia of the bowel wall. Then thickness also, you can see how it has increased. Then you see the blood supply going down, but thickness remaining. Then thinning happens or sloughing happens, and then end stage is perforation. So this is how the progression of the pathology which happens. Superior mesenteric artery Doppler, go for thickness at least, and velocity if you can, otherwise leave it more than 120, or thickness more than 3.7. Normal is 2.7 to 3.7. Stages, thickening early stage and thinning in the late stage. So when it is less than 1 mm, that is the time you need to call the surgeon and request him to go for a removing of the gut, because initially there is thickening, hyperemia, then blood supply ischemia, then thinning and sloughing. The next stage is sloughing. So you cannot wait beyond that. So this is the time you need to call. So this is how the bowel looks like. You can see bowel wall thinning with complex peritoneal effusion, septate outside the bowel wall, and you can see unhealthy intestinal structure. You know that the signature is completely lost. This is how exactly it looks like. Necrotic non-perfused bowel versus perfused bowel. This is the pattern which I was talking about. So let us come to case discussion. So quickly what I'll do is, so this is the case and I'll put an X-ray, and then you have to tell me in the chat box whether what stage of bell staging you would classify this. There is a 28-weeker with the corrected gestational age of 30 weeks with abdominal distension, coffee ground aspirate, mechanically ventilated, apnea, acceptable blood gases. So this is the X-ray. Can anybody tell me whether there is NEC or no NEC? Or if it is NEC, what is the stage of NEC? Because after this, we're going to put the ultrasound probe, and which is going to blow your mind. Okay, so 1A, I've got one response. Other people, please put your thing. What stage of clinical thing? 1B. Okay. Wow, few more seconds, I'll wait. 1B. Okay, so the majority is telling 1B. Okay. Yeah, so now let us go with, yeah, this is what you look like, you know, between 1A to 1B or up to max. Now, I'm going to put, so can anybody tell me now, with ultrasound features, what I've told, with the Doppler which I've put side by side, normal, abnormal? Yeah. Do you see any pattern, circular pattern, zebra pattern, or Y pattern? No. You can see nice intestinal motility. So you had a thing that it was NEC, and then you would have stopped the feed, and exactly it is normal. So you would have stopped the feed. This is how I'll play it again. You can see nice movement of the bowel and the Doppler as well. So what you have to do? Nothing. Just restart the feed and nothing, because X-ray has misguided us, but with ultrasound, it gave a clear idea whether it is normal or abnormal. So case number 2, there is a 25 weeks with corrected gestation of 29 weeks, abdominal distension, coffee brown aspirate, stable hemodynamics, total count of 13.9, platelet of 84,000, lactate and CRP have put. Now X-ray. Now can anybody tell me what is the stage of disease it is in? With X-ray, bell staging, which one you would put? So somebody has told 2A, correct? Okay. Yeah, you can take a guess. It's okay. We cannot see the face. It's all right. 2A, 2B. So 2A. So the majority are telling 2A. 2A. Yeah. Yeah. So this is what you are thinking. So now let us play the video. Please observe the hand where it is moving. You can see an exudate, a sluggish bowel movement. Can you see and pneumatosis, intestinalysis? sluggish, thinning of loss of intestinal structure, abnormal Doppler. So it is almost on a verge of perforation. What stage you would put now after ultrasound? With X-ray, you thought it was 2A. Now with ultrasound, what do you think it is? Air anterior to the liver. Yes. Okay. 3A. 3A. Exactly. So I'll play it again. I'll play it again. You can see even with the hand which is moving there. No? So that is the exudative fluid. You can see the bowel down there with sluggish bowel movement, lot of PI, pneumatosis intestinalis is there. So this is how it changed. You are in 2A. Now we have jumped to 3A because it's going to rupture if you don't effectively treat it. So can you see the Doppler now of the same baby? There is a Y pattern. There is a circular pattern. In another video, you can see almost decreasing. Yeah. So we have put two picture of pneumatosis intestinalis within the muscular mucosa and a normal bowel side by side. I'm sure yes, hyperemia was there on the left side and less of blood supply on the right side. Now this picture, I've compared both normal healthy looking bowel versus the affected bowel. Are you people able to appreciate? You can see at different layers of the intestinal wall signature. On the other side, you can see the white dot. Yeah. Put in Facebook and WhatsApp. This is how exactly it looks like. From 2A, it dropped down to 3A because management is completely changed. If we were waiting that till it is perforated, we would have lost the baby. That's why my topic was, this is the time to challenge bowel staging. So with ultrasound, yes, whole perspective in live sound what is happening. One more scenario. I request the participants to just mute. Yeah. So here is one more case, 23-weeker with post-corrected age of 25 weeks on conventional ventilator and with abdominal distension, gram-negative sepsis, and these are the findings. Sensitivity of the ultrasound is very, very high. There are a lot of studies which has been done. It is beyond doubt. It is proved that it is quite very, very, very sensitive. So this is the X-ray. Can anybody tell me what stage of bell staging you would like to put this particular case and this X-ray? Yeah. 3A. So Abhishek Paul has written 3A. So okay, 3B with perforation, pneumoperitoneum. Okay. So let us break the thing. So impression, it could be septic ileus, NEC with and medical manage, NEC with surgical management, or none of the above. Which one you would do for this baby? With 3A, few of them we put 3B. What you would like to do with the baby? Will you go with medical management or with the surgical management? 3. Okay. Which option? आपके पास में 4 option है. You have to choose one. Which one you would like to go with? None of the above. Okay. 3. Surgical 2. See, there is so much confusion. Even within our neonatologists who are seeing the X-ray and who are having the same history still with the X-ray, we are having this particular confusion. Now I'm going to put a thing. Can you see? This is the liver. Yeah. So this is the liver, which is showing there is an assisted layer as well, where you have seen on the lateral X-ray. Yeah. Can you see sluggish bowel movement, exudate fluid? See how it is like as if it is beating. This is not the typical LT, and there is loss of intestinal structure, signature, and this is the pattern. So it's not, it's having the abnormal Doppler pattern. Okay. So grossly abnormal and ischemic bowel, no peristalsis, encysted air, thinning of the walls, sloughing. So you have to go for surgical management. 26-weeker, 33 weeks, corrected gestation on CPAP, intubated, CRP, So I put a probe. We had suspicion of NEC. Now probe is put on the liver. What do you see? Unless you are blind, you will not miss this. Portal venous gas. Yeah. Are you able to appreciate? Is the video clear? Yeah. So this is the beauty of the X-ray. And these are the people whom I have learned with. One is in the center, Daniel Linkiston. He is the father of ultrasound chest, and he is the one who has devised fast protocol, e-fast protocol. We have our own Yogin, Dr. Yogin, Dr. Samir Gupta, Dr. Kiran More, and my guru, Dr. Dinakar sir, who has actually taught me the ultrasound and given me an idea. And the down photo is in John Hopkins, where I had attended the point of care ultrasound course. So now we are ready with the unmute. Yeah, sir, Bhushan sir, now we are ready to take up the questions. I request our audience to pose the question from the beginning, and so that we'll take one by one. Raghavendra, Raghavendra, I have unmuted. Dr. Dinakar sir, unmuted. Yeah. Hello. Yeah. Bidri sir.
Hi. First, it was very nice. Especially all the 3 lectures were very good, and ultrasound I learned so many new things. Is wonderful. Keep it up. All the best.
Sir, Dinakar sir, will you moderate the question, sir?
Yes, sir. Yes, sir. Please, sir. Okay. Moderate the questions. Yes. Charts.
The Zoom
From the beginning. Okay.
chat.
From the beginning.
They have put
Lot of questions are for Dr. Phanibushan, sir. Many people have told all the lectures are very good, excellent.
Yes.
Only few people have not heard, because probably they are having their own problem with their computer or their laptop or their this thing. So, but other people, everybody heard the what is it, Dr. Raghavendra and other people. So there was no problem with Raghavendra or anybody.